Happy Wednesday, and thank you all for joining us for the 2020-2022 State Health Improvement Plan Maternal and Infant Health Work Team meeting today. This is Regina Clay, Health Policy Analyst at the Health Policy Institute of Ohio. Just a few housekeeping items before we get started with the meeting. For now, everyone is in listen-only mode. We want this to be a highly interactive meeting, so if you have questions or comments, please type them into the question box here. If you would like to talk during today's discussion, raise your hand and we will unmute you. If you have muted yourself, you'll need to unmute yourself in order for everyone else to hear your comments. Once again, make sure that you've entered your audio PIN. You need to log into the webinar first before calling in order to get your PIN. The meeting slides for today, including the recording of today's webinar, can be located on HPIO's Shaw Ship webpage. So you can get all of that information. And here is the list of all the stakeholders involved in the SHIP. And to locate yourself, you want to look at the foundation. The Maternal and Infant Health Work Team is outlined in red and almost a little to the left or the middle. I'd like to take a moment to introduce my colleagues at HPIO joining us today. In the room, we have Amy Bush-Stevens, Becky Carroll, Zach Reed, Alana Clark-Kirk, and Julia Dion. Also joining us is Elizabeth Comray from the Ohio Department of Health. And on your screen, you should also see a list of today's webinar participants. In a moment, Amy will provide some more background on the SHIP process and purpose and list of outcomes and indicators for maternal and infant health. Then we will move into some discussion on setting overall targets, identifying priority populations, and setting priority population targets. Today's meeting will conclude with next steps for the project. Our objective for the meeting today is for HPIO and ODH to have the guidance needed to finalize overall targets, priority populations, and priority populations targets for maternal and infant health. No final decisions will be made on the call today, but your input will guide final decisions that are made over the next few weeks. And now I'll turn it over to Amy to share more about the SHIP process and purpose.
Thank you, Regina. Good morning, everyone. Looks like we have a good group of about 20 folks on the call so far. So thank you so much for joining us. I'm going to start with a quick reminder about why we're here, the purpose and process for the State Health Improvement Plan. This is the timeline for the SHIP. So we will be delivering the final SHIP to the Department of Health by the end of September, and we are here in July, sort of in the middle of the process. This is the target setting phase of the work. And then later this month and moving into August, we'll be looking at strategies to include in the SHIP. And throughout this process, there is a parallel maternal and child health assessment happening. So with several touch points and coordination with the maternal and child health, maternal, infant, early childhood, home visiting, or MCV assessment. And I think some of the folks on the call have probably been involved in that part of the work as well. The purpose of the SHIP is to get us all rowing in the same direction to improve population health in Ohio. That's why it's important for us to be concise and prioritize toward common goals. We know that prioritizing is difficult work, but it's necessary if we're going to be strategic about working together to improve outcomes. The SHIP will be used as a tool to align state agencies, and we have a steering committee for this work that's made up of representatives, directors, or their designees of these state agencies. So we're really excited to be working with not only ODH, but other agencies as well, including sectors beyond health. The SHIP is also about improving alignment and collaboration at the local level with all of these types of local level partners. The SHIP is our opportunity to track progress over time. This chart takes an early look at Ohio's progress on the objectives from the previous SHIP. And here, green indicates things are improving, yellow means there's little or no detectable change, red means things are getting better. Clearly, we have our work cut out for us. The goal of this work is, of course, to get us to green. So this is a vision of what we would like Ohio's performance to look like in the future. And so the SHIP is really all about improvement and progress. And the goal is to ensure that all Ohioans have the opportunity to achieve their full health potential. And this means eliminating disparities and inequity to achieve equity. And now let's take a look at the framework for the SHIP overall. This will be guiding all of our work. This is a new framework. This is the latest version. And it will, for those of you who are familiar with the previous SHIP, you'll notice that it's somewhat different. We made several revisions this time around. So we flipped the SHIP by putting a focus on those blue health factors along the left, including community conditions or social determinants of health. We've simplified some of the language with those questions across the top, and then elevated equity within the framework. And here's where maternal and infant health fits into this overall picture. And throughout our conversation today, keep in mind the connections between all of these different factors and outcomes. We know that there are many different relationships between all of these different variables. These are the main components of the SHIP. We have our SMART objectives, priority populations. Those are groups that have experienced worse health outcomes than the state overall, evidence-based strategies, and strategies to reduce disparities, inequities, racism, and discrimination. Today, we're going to be focused here on these SMART objectives and the priority populations. And then as we move into August, we'll be looking at the strategies. As a reminder, this is our objective for the call today. Okay, now we want to do a recap of where we are with the maternal and infant health outcomes and indicators and how we got here. To remind you of the prioritization process, we started this work back in October of 2018 with regional forums where we gathered input from local stakeholders. So that's that local stakeholder input piece in the top left. Then we also looked at secondary data in the state health assessment, and ODH will be releasing the 2019 state health assessment soon. We shared the information from these sources with the steering committee and the advisory committee for the SHA SHIP, and also with the steering committee for the MCH McV project. And then at our June 4th advisory committee meeting, we had a small group discussion that was focused on maternal and infant health. Then we had a prioritization survey that was out in early June, and we used all of the feedback from these different sources to help us prioritize a concise set of desired outcomes and specific indicators for maternal and infant health. And now we want to get a sense of how many of you were able to participate in that small group conversation at the June 4th meeting, just to get a sense of how familiar folks are on the call with what we've done so far. So we're referring to the June 4th advisory committee meeting that was at HPIO. So let us know, did you participate in that meeting and attend the small group conversation on maternal and infant health? Did you attend that meeting but participated in a different small group conversation? No, but you were able to review the materials that were posted online, or no, you weren't able to participate at all. So please take a minute to fill out that poll so we have a sense of who's on the call today. And if you are new to this group, we welcome you and encourage you to check out all of the background material that's posted on the HPIO SHA-SHIP page, including all of the recordings. So whenever we do a webinar meeting, we post the recording, and we always post slides and other meeting materials as well. Okay, looks like we're just about done with the poll. Alana's going to share the results with us. Okay, so about a quarter of you were part of that small group conversation, but looks like most of you were not able to be at that meeting but have reviewed the materials online. So it looks like pretty good familiarity with where we've been so far. Okay, so this is the list of desired outcomes that we have prioritized for maternal and infant health. And Zach and Beth are going to get into more of the details on this in a minute. But just as a reminder, these were the criteria that we used to narrow down this list of outcomes and indicators. And then this is greater detail looking specifically at the indicators and the sources. And this is similar to what was included in the previous SHIP, although maternal mortality is a new indicator that we're including in the SHIP this time around. And in a minute, we are going to open things up for discussion. But first, I want to provide some background information on targets and priority populations. This is part of setting SMART objectives, and I'm sure many of you on the call are familiar with SMART objectives. This is an example of what SMART objectives look like. This is from the previous SHIP, and you can see the baseline data, the target data, and what we're focused on today are getting some guidance on how to set those targets. And this is an example of what it looks like when we report out on those targets from the progress report. So our goal is to update this so that we can report out on that in an updated way, and also to update the priority populations. Looking at the components of a SMART objective, specific and measurable refers to the indicator and the source. We've already done this work for maternal and infant health. That's the list that I shared a minute ago and that we'll be looking at more closely in a minute. And then achievable and realistic refers to the target data value, and that's what we'll be talking more about today. Time-bound refers to specific years for the baseline and target. And we've set 2022 as the target year for all objectives in the SHIP, and the baselines will vary depending on the data source. It's worth spending a bit more time talking about these two words here, achievable and realistic. We think it's also important to be aspirational when we're setting targets. So there's sort of a tension here between being achievable and realistic and being aspirational. As we set our targets, it could look like this, so weighted towards the aspirational end, focusing more on really reaching for the stars. Or we could be more incremental in our approach in a way that might be seen as more realistic. Or we could strike a balance where we would look at what seems achievable given the current trends, but then reach a bit and push ourselves for a better outcome than we would see with the status quo. So now we would love to hear your thoughts on this question. So when setting targets for the ship, do you think the emphasis should be on being achievable and realistic, aspirational, or striking a balance between the two, and why? And so we encourage you to raise your hands so that you can speak to the group. You should see that little hand icon. Hopefully you've put in your audio pin. If you have muted yourself, you'll need to unmute yourself. But once your hand is raised, we will let you know that we see you and unmute you. Alternatively, you can use the question box if you want to type in comments or questions, and we will try to read all of those aloud. But we really do encourage you to raise your hand so we hear some other voices beside my voice on the call this morning. So what are your thoughts on this balance or this tension between achievable and aspirational? And looks like we have a hand raised. Ilka, go
Yes,
ahead.
hello. Can you guys hear me? Can you
We
hear
can.
me?
Yeah.
Okay, great. Fantastic. So this is Elka, and I think there needs to be a balance between having achievable and realistic targets. I think it's really frustrating if your targets are set in such a way that they're really not, achievable. But at the same time, I think you have to have the targets be a little bit aspirational, right? So that you're working towards something to really look at that improvement. So I would say a balance between achievable, realistic targets that we can come close to achieving based on the data that we have, and then having the targets also being aspirational to move towards better outcomes overall would be my suggestion.
Okay, thank you, Ilka. We also have a comment here from Jody, a balance between the two. If we just try for things we know are achievable, we aren't reaching up towards real change that we aspire to. And then from Tanya, strike a balance based on our last 2-year cycle. Would be good to see some success, setting potentially achievable goals, but also we've lots of work to do for maternal and infant health, so we need to push ourselves. From Raina, I'm in agreement for balance between the two choices. And again from Raina, for all the reasons shared. Thank you. Any other comments? Would anyone else like to speak to this? Okay. Move us along to another question here. We know that some of you have probably had experiences setting targets in your own communities or organizations. So what experiences have you had with setting targets in your organization or community? Have you had any experiences with setting targets that were too ambitious or not ambitious enough? And what are the lessons learned to inform the ship? So again, we're gonna pause here for you to raise your hand or to type thoughts into the question box. I do have a comment here on the previous question from Taylor. Targets need to be achievable, but aspirational enough that the outcomes will actually make a difference. If you set them too low, are we really making a difference in health? All right, thank you for that. And on this question here, we would just love to hear words of wisdom from anyone who has maybe had a good experience or a not so good experience with setting targets and tracking progress over time in your own work. So this could be at a local health department CHIP or a hospital's implementation strategy, maybe state agency experience, maybe something more internal to your own organization. We have a hand raised from Brittany. Brittany, go ahead. Unmute yourself, Brittany. We can't hear you yet.
Can you hear me now?
Now we can hear you.
Okay, sorry about that. I know I sat in on 4 of these, but this one I did want to comment on once again. I'm not sure if it fits here or in a different section, but I know that when we have set targets at the local level or even at the state level, as it specifically pertains to infant mortality, this is really tricky because we just had this conversation about being achievable versus aspirational. And when we set targets, we all know that the African American population is definitely has higher infant mortality rates. So when we were, I guess, setting targets for these, and we had one for the overall population, for the white population, African American, it got really tricky because in theory, we want everybody to have that same nice low rate. I mean, we want it to be 0, but that also isn't going to be achievable when you look at how far some of the populations would have to go. And so when we set them separately, that also sends another message. Wait a minute, why are we not wanting African American babies to also get to this rate, the same as whites, but yet is it going to be achievable? So I think that this is of all of the sections of the ship, this is probably one of the hardest ones for me to process as far as what the target data points should be. And I'm not an expert in this area at all. I just have seen this happen in many, many counties in the state.
Yeah, it's definitely challenging, and you're a trooper, Brittany, for being on the 4th call. So this is the 4th in a series of 6 work team meetings on target setting, and thank you those who are able to participate in multiple calls. So thank you for that, Brittany. And I have a comment here from Sue Ellen. Previously, we used trend data to see what a realistic decrease was happening, and then deciding how much bigger we wish to set it, but to make a little bit of a reach, but not so far that it was completely unrealistic. All right, thank you, Sue Ellen. Do we have any other hands raised? Yes, we do. Danielle, go ahead.
Wanted to ask the question, are we going to set targets that would separate out African American infant mortality from overall? Because to Brittany's point, I think that sometimes, well, actually 2 things. I think you can achieve the balance that we were talking about by disaggregating the data. But I have been in other meetings where we've set targets that were not ambitious enough, but it was because there were other underlying issues that are going on, and that, may not come to the surface until you put that number out there, you extremely overachieve whatever it is, and then you have all of this conversation like, why were we afraid to do it in the first place? So I think that if, to my first point, if you can separate out, if we can have a target just specific to African American, I think you can get to both of them, and it also leads to interesting conversations that might develop into other types of interventions and strategies we need to be paying attention to.
Yeah, absolutely. And that your comment is an excellent prelude to the next section that I'm going to cover. So now we'll talk about priority populations and then have a little bit more discussion about that. So let's take a look at the priority populations from the previous SHIP. There we go. These are the groups of Ohioans who have had worse health outcomes than the overall population. These are just examples of priority populations that were included in the last SHIP. So we were looking at race, ethnicity, age, gender, income, education, disability status, and geography, depending on what was available from the data source. So there are some sources that don't allow us to break these things out. In a minute, Zach is going to share the data that we have for maternal and infant health so that we can talk more specifically for maternal and infant health. But first, we want to talk more generally about priority populations and setting targets. So there are a few different ways that we can think about setting targets for priority populations. And to illustrate this, we're going to use the apple tree metaphor that I'm sure some of you have seen before in defining equality versus equity. And in these pictures, apples represent optimal health outcomes. The ground is representing social, economic, and physical environments, and then the crates are policies, programs, and other resources. In this first image, all three people have the same policies and programs, so the same crates, but two of them can't reach the optimal outcomes because of where they're starting from. In the second one, the apple crates are tailored and targeted so that everyone achieves optimal health outcomes. So this is what equity looks like. And now we're going to use this picture to talk about two ways to set targets for priority populations in the SHIP. In the first approach here, we're calling universal targets, we would set the same target for everyone. So the apple would be at the same level for everyone. For example, the target for the Black infant mortality rate would be the same as the overall Ohio infant mortality rate target. This approach makes the case that we must eliminate disparities and inequities, and it's consistent with the goal of achieving equity. To be effective, of course, it needs to drive targeted allocation of resources and funding and power. So that's those apple crates. So in other words, the targets are universal, but the strategies, those apple crates, need to be different. They need to be targeted and tailored with more resources directed towards groups who have the furthest to go to reach the apple. So that's one way that we could look at it. Another way that we could look at it, we're calling population varied targets. So here the targets would be different for different populations, and we would set those targets based on trends and baseline data. This approach is not as consistent with the goal of achieving equity, but might be seen as being more realistic, bringing us back again to that balance, that tension between being aspirational and realistic. And so now we would love to hear further thoughts on this and which approach you think should be used in the SHIP. So would you prefer or would you recommend that we use this universal targets approach where we would have, for example, the same target for overall infant mortality as for Black infant mortality, and then prompt a conversation about how to make sure those apple crates were tailored and targeted, or a population varied target approach where we would have a different target for the overall infant mortality rate than for the Black infant mortality rate, for example. So please raise your hands if you have thoughts for the group on this, or you can use the question box. And I think what Brittany and Brandy were sharing earlier was starting to get at this. It looks like we have a hand raised. Melissa, go ahead.
Hi, thank you. I would advocate for having universal targets at this point because I think it really does help us clear up what the barriers are in the community, whether it's funding or policy, et cetera, to achieving them. And I think when we continue to have different targets, not only are the optics I mean, we see this, in the community, the optics can be really terrible because it can unfortunately denote that we don't think that they should be improving in an equal way. But instead of, I think, thinking of them as, unrealistic, I liked the language of having an equitable target instead of an ambitious target. So that's my 2 cents. Thanks.
Okay, thanks, Melissa. And I've got a comment here from Sue Ellen. Can we utilize middle term and long-term columns where the population varied targets are given, but long-term universal goal is stated? Okay, that's an approach we hadn't thought of. Thank you, Sue Ellen. Marie has her hand up. Go ahead, Marie.
Hi, thanks. I think that I think the universal target idea resonates for the reasons that we've talked about. But when I think about it, I think that if we create a universal target, then we can have an equitable use of resources that says, here's our target, we're going to start by putting our resources where the need is the greatest. And that results in the people who have the greatest disparity seeing the most attention at the outset, and that appears to be also people seem to understand that. Yes, we want everybody to get to this place. We're going to start with the people who are in the worst shape, because that's where we have the most space that we need to improve.
Yeah, thank you. We have a comment here from Danielle. She says population varied targets. Danielle, do you want to say a little bit more about why you think that's a better approach?
Yeah, I'm thinking population varied targets just because with the universal target, I feel like you can still say, oh, we didn't reach the African American rate, but we were able to achieve blah, blah, blah. And it puts a lot of stock in people having to do specific types of interventions that we don't really have a lot of control over or awareness as to what their knowledge is around what the most effective intervention would be, etc. I like the population varied targets because it's pretty crystal clear on what needs to happen where, and hopefully will push people to think about in terms of resource allocation where that needs to occur.
Okay. And we have another hand raised, Amanda. Go ahead, Amanda. Make sure you're unmuted on your end. Go ahead, Amanda. No, we're not able to hear you. So far I'm hearing definitely the importance of focusing on the resources. So regardless of if we go with universal or population varied targets, which I'm hearing kind of a mix of opinion on that, definitely hearing that we need to be focused on those apple crates and targeting and tailoring those. Okay, in the interest of time, I'm gonna move us along to one more discussion question. What other suggestions do you have for addressing equity in the target setting process? And are there other issues that should be considered in setting priority population targets? Do you have a comment here from Raina? Population varied targets with director strategies and sufficient resources. Jody says population varied to address health inequities. Raina says rather, oh, just correcting a typo, okay. Specific strategies based on need and sufficient resources, okay. Any other suggestions or considerations here? We're gonna move along in a minute here to Zach and Beth to talk more specifically about the maternal and infant health indicators. And no other thoughts on equity? Okay, I am going to pass the baton to Zach. Go for it.
Thank you, Amy. So just as a quick reminder, our objective by the end of the meeting is to gather the guidance that we need to finalize overall targets, priority populations, and then targets for those priority populations for the maternal and infant health indicators. This is just a quick reminder of the desired outcomes and indicators that were selected based on your feedback and then consultation with subject matter experts, as well as the Maternal Child Health and McVie Steering Committee. So the format of this next part of our conversation is going to be to review data related to each one of the desired outcomes and indicators, and then to answer a series of questions about each indicator. The first outcome we'll take a look at is reduced preterm births. In Ohio in 2017, 10.4% of births occurred before the 37th week of pregnancy. This metric is included in the online SHA, and in that data we can see that the rate for Ohio is higher than the rate for the US, 10.4 in Ohio, and then 9.9% in the US. This is a measure that has a Healthy People 2020 target of 9.4%. On other work team calls, we've heard that we need to be aware of and focused on those targets. And then this metric was included in the 2017 to 2019 SHIP, and there was no notable change in this particular metric. In 2017, 10.3% of births were preterm, and then in 2017, again, 10.4%. So now we'll move into a discussion question, and that is, what factors do you think are important to consider when we set targets for this indicator? Specifically, are there measurement issues we should be aware of? Is there a federal, state, or local policy or policy changes on the horizon that might impact movement on this metric? Are there broader trends or other issues that we ought to consider? Again, please raise your hand so that the group can hear your insights, or type into the questions box. All right. Not seeing any hands. Oh, we do have one just popped up. Marie, if you'd like to go ahead.
Sure. My mom says nature abhors a vacuum, so here I am. So the policy change piece, of course, draws me, for those of you who know me. I do think that, but I wasn't exactly sure about your framing of that. You had said federal, state, and local policy changes that are kind of seem like coming down the pike or something like that. I think of it more in terms of policy. Maybe this is the same thing. Policy changes that might be achievable in a particular context that would help a target be more attainable. It seems like we have a lot of information about in that arena that we could act on, and that would be my focus.
Okay, thank you. And we have a comment here from Amanda. I would consider moving beyond vital statistics data and looking at other data sources to understand why babies are born preterm. Thank you, Amanda. Okay. Yeah, and a lot of those factors are being considered in other parts of the SHIP. For instance, taking a look particularly at smoking during pregnancy and the health behaviors, looking at housing in terms of community conditions as well as poverty. So we are looking at some of those factors that lead to preterm birth and considering those in other work teams. So thank you very much for that suggestion. And Jody suggests that the HPIO report to the Legislative Service Commission from 2017 has lots of policy recommendations that look across all areas and that impact maternal health. And many of those strategies and recommendations will be considered as we move into the strategy selection part of the SHIP process in the coming weeks. David, yes, if you type your comments into the questions box, we are receiving them. We have moved some conversation along in the interest of time, so I apologize for that if we passed over your comment. But everything that comes into the questions box is being recorded as part of the notes for the meeting, for sure. All right. If there's no other input on this discussion question here, I think we'll move on to priority populations. So what you see here is data for the priority populations that were identified in the 2017 to 2019 SHIP. There was no notable change for any of these groups between 2015 and 2017. The Ohio Department of Health confirmed that these groups continue to experience disparities in preterm birth outcomes. And for continuity's sake, we intend to keep these priority populations in the next iteration of the SHIP. So if there is another group that you think we ought to consider to elevate as a priority population, please do let us know during the next segment of our discussion. So now we're going to ask for your input on considerations for setting targets for these priority populations. We've already heard overall sort of how the group is feeling about population versus universal targets, but we'd like to hear specifically about preterm birth. So what factors do you think are important to consider when setting the targets for these priority populations for preterm birth? And again, we've given you some prompts in the bullets, but if there are other issues that you think we ought to elevate, please do that now. You can raise your hand to talk or type your question into the questions box. Okay, looks like we've got a question for Marie. Thank you for filling the vacuum again.
So this is the framing of this question when you're talking about preterm births really pushes me to look well before pregnancy, because when we look at preterm birth and decide and think, okay, how are we going to focus on this? If we start at the time of the preterm birth or shortly before, to me, we've already lost the battle at that point. We just have to go so much farther back. And so I don't know if that's broader trends in terms of the health of women who are getting pregnant, or the community conditions of women when they're getting pregnant, or how to conceive of that. You like that? But I really feel like that's the piece that I feel like we just need to have a much broader perspective than a medical perspective when we're thinking about preterm births, and maybe it just jumps out at me more with this particular group, because when you say preterm births, that already puts me in the hospital at 36 weeks, and so that's where my focus. I think it's easy for our focus to become that arena.
So I guess I'm hearing a sense from the group that really the focus ought to be on those improving those conditions that lead to preterm birth, and based on the movement we see in those targets and the action that we see on policies in those arenas, we might be able to better predict where preterm birth will be moving. And want to really encourage any of you who are interested in how the targets will be set related to housing, smoking during pregnancy, poverty, all of these issues, to please consider coming to the Community Conditions Work Team meeting, which is next week on July the 25th. I'm looking at my colleagues. Yes, it's on July the 25th, and if you're interested in getting the registration information for that, you can reach out to any of us. right. And Ilka, if you'd like to go ahead and talk, please do so.
Yes, I'm concerned specifically about women with disabilities, and why I understand that it can't be a priority population simply because we actually don't have good data on this group, as well as it's probably not a group that is big enough. I'm just wondering if there's any way to address this, because we have almost no data on women with disabilities who get pregnant and then have children preterm or with disabilities themselves.
Thank you very much for elevating that. And that's likely something that we can address through the strategies that are selected, or at least in narrative around those strategies being tailored to meet the needs of women. Raina, if you'd like to go ahead and talk, please go ahead now. Thank you for your comment here. I haven't had a chance to read it fully, but go ahead and talk.
Hi, this is Raina. The comment I made was that with regard to your second bullet, I believe it was local, state, and federal policy, the lack thereof can also have a huge impact on social determinants of health. And for example, with housing in particular, and I know we've had that be a group in and of itself with a lot of HPIO work, but when an extreme example, when a young woman who's been recently released from being incarcerated finds herself to be a future mother, there's not enough legislative support to help her obtain housing, in that just based on her previous incarceration, that prevents her from being eligible for certain housing that's supported through state or federal dollars. And that is not a good situation. That we have to have tightened or better legislation that supports her, because now, with her not being able to have a home that's consistent, she's couch surfing, or she's homeless and staying in a shelter. So that in and of itself is a stressor. If she's not in a situation where she feels safe, and she may not be safe, that is also an issue. So without the lack of, state, federal, and local policy, or the lack of sufficient policy, can be just as bad as having a policy in place that's just not, it's too light. It doesn't put enough onus or enough bite into having someone who does provide housing for those that are recently incarcerated. It's terrible, and we see that an awful lot in the work with our mothers who are expecting children, when we're helping them through the support of our certified hubs.
Okay, thank you very much for the comment. In the interest of time, I am going to move us along to the next desired outcome. Sorry, I was using the wrong clicker there. Our next desired outcome is reduce infant mortality. As seen in the online SHA, Ohio's infant mortality rate in 2017 was 7.2 deaths before the age of 1, and that's a rate per 1,000 live births. This rate has been, it has fluctuated, but it's been relatively stable for the last decade. In 2016, Ohio's infant mortality rate was higher than the US rate, 7.4 deaths per 1,000 live births in Ohio compared to 5.9 deaths per 1,000 births in the US. So taking into consideration all of the conversation that we've had about the need to address community conditions, are there other factors that you think are important to consider when setting targets for this indicator? Again, please raise your hand to comment or type your questions into the question box, or excuse me, your comments even into the questions box. Again, everything typed in there will be included as part of the record for the meeting. And Marie, I absolve you from saying anything if you don't need to feel like you have to fill the vacuum, but you can. You're welcome, Marie. All right, well, not seeing any hands, and again, very much hearing and considering the feedback about community conditions we heard during the previous conversation, we'll go ahead and move forward in the slides. So in 2017, the infant mortality rate for Black Ohioans was 15.8. This was more than 3 times the rate for white Ohioans. This disparity, again, has persisted over the last decade. And in the online SHA, again, we see that Ohio's rate of infant mortality is higher than the US for all the racial and ethnic groups where we can get stable estimates. Again, for continuity, we intend to keep this priority population, but if there is another group you think we ought to consider, please do bring that up during our next discussion. So again, our question is, what factors do you think are important to consider when setting targets for, in this case, this priority population? All right. So we'll go ahead and move on again. Oops. The last desired outcome that we'll talk about is reduce maternal morbidity. Based on advisory group feedback, as well as feedback from the MCH and McVie steering committees and the Ohio Department of Health's Maternal and Child Health Bureau staff, we added reduced maternal morbidity to this version of the SHIP. There was some discussion about adding maternal mortality as well, but we settled on this one desired outcome. Elizabeth Conray from the Center for Disease Control, who is a senior epidemiology assignee to the Division of Maternal and Child Health at the Ohio Department of Health, is here to share some more information about this outcome and our associated indicators. So now I'll turn it over to Elizabeth.
Good morning. Thank you, Zach. So I'm just going to share a little bit of background information on the data and indicators that are possible for maternal morbidity. I'm going to talk about the definitions, what's included in the definitions, where the data come from, and some of the limitations that will affect our discussion and thinking about the setting of targets and priority populations. Maternal morbidity, or severe maternal morbidity specifically, is defined as an unexpected outcome of labor and delivery that results in significant short or long-term consequences to a woman's health. It's different than maternal mortality. Obviously, maternal mortality, specifically pregnancy-related maternal mortality, has a death from a cause related to or aggravated by pregnancy or its management that happens within a year of the end of pregnancy, regardless of the outcome of that pregnancy. I'm going to focus on maternal morbidity unless anyone has any questions about mortality, though. So what's included in maternal morbidity? There's currently a list of 18 conditions that CDC provides guidance on and recommends using in measuring severe maternal morbidity. They include shock, disseminated intravascular coagulation, transfusion, severe complications of anesthesia, adult respiratory syndrome, eclampsia, acute myocardial infarction, sepsis, aneurysm, hysterectomy, puerperal cerebrovascular disease, air or thrombotic embolism, cardiac arrest, heart failure or arrest during a procedure, amniotic fluid embolism, and pulmonary embolism. And that's the list of conditions. And you'll also note that sometimes severe maternal morbidity is reported without transfusion, and that's because although transfusion is the most common severe maternal morbidity reported, because of the way we capture transfusion in the data source, it's not very specific and can include transfusions that don't indicate severe morbidity, as well as transfusions that indicate severe morbidity. So it's not very specific. So that leads us to where the data come from. We measure severe maternal morbidity generally from hospital discharge data. Nationally, there are some national and state data that use HCUP, the National Inpatient Sample, for this. However, Ohio limits the use of its data in HCUP, so you have to get special permission to use the Ohio data in HCUP, which is different from most other states. So it's a bit limited and challenging to get that data out of there. However, the Ohio Department of Health has a relationship with the Ohio Hospital Association, whereby we request and receive data from Ohio Hospital Association on inpatient discharges when we request it. So we have been using at the Ohio Department of Health the OHA hospital discharge data as the data source for this, which is essentially the same as what's in HCUP. Some limitations I just want to touch on are that there is a little bit of a lag. It's not that great though. We are able to get a full data set for a calendar year before the end of the next year. We're also able to get quarterly data, so not full years if we want to have preliminary data on less than a year as well, or do rolling averages. Because of the switch from ICD-9 to ICD-10 data during 2015, and the fact that we can't compare the severe maternal morbidity estimates that come from ICD-9 to ICD-10 because of some changes. We don't really have much trend data, so that makes it a little more challenging to set targets. But I just want to point that out, that we can look at 2016 and soon 2017, but we don't have trend data before that using the same indicators. And the subgroups that we're able to look at are also limited. We can look at race and ethnicity, maternal age, insurance status and insurance source, and geography, so the county of the residents. We don't have some of the other indicators that we like to look at, including education, and has been just brought up in this call. We don't have an indicator of disability in the Ohio hospital discharge data. And one other assumption that we'll move forward with is assuming that the Ohio Hospital Association will continue to share these data with ODH so that we can monitor this indicator.
Thank you. So given all of that detailed explanation of the maternal mortality and, excuse me, I forgot to unmute myself. So thank you for that discussion of the maternal mortality and morbidity metrics. So based on all of that, are there other factors that you think are important to consider when setting the targets for this indicator? All right. So we have several people who have offered feedback. First is that maternal age for non-Hispanic Black infant mortality and preterm birth will be an important consideration due to weathering. Weighing in that measurement issues are a consideration, reporting from hospitals on, quote, near misses is a big issue. Need to consider maternal mental health issues in this area was not mentioned as one of the morbidity conditions. Thank you. And then the question is, are these data available at the local level? And then another factor we need to consider is mother's health before pregnancy. So I'm going to ask Elizabeth to respond to that question about, are these data available at the local level?
Thanks, Amanda, for that question. They are available at the local level in that we do have an indicator for maternal county of residence in the data set that we have and can make estimates. Of course, any data that's released has to be approved by OHA as well, but we assume that we can get those out to you and have been working on getting some updated estimates as we work through the ICD-10 coding and updating all of our analyses using the ICD-10 data.
Thank you very much. If there's other questions or comments, please go ahead and raise your hand or type them into the questions box. Not seeing any others, we'll go ahead in the interest of time and move on. So I'll turn it over to my colleague, Regina, who's going to talk about some next steps.
All right, thank you, Zach. So moving forward, HPIO will send out a link to the final SMART objectives list with targets by August. And here are the dates and times for those next set of strategy selection meetings. All of the next set of meetings that you see are in person at HPIO and incorporate small group discussions. So in-person attendance is required. There won't be a call-in option for these meetings. When thinking about what meetings you would like to attend, just consider the topics that best align with your skills, expertise, and availability. And we thank all of the participants who have been on the 4 webinars with us thus far. And moving forward, if you want to attend the next set of 3 meetings, we certainly welcome that level of participation. Lastly, we want to thank Elizabeth Conray from ODH for sharing her expertise and time with us today. We appreciate that. This concludes today's webinar. We thank you for your time. We hope you have a great rest of the morning and happy International World Justice Day.